Hi, I am Dr. Rajiv. Welcome back to my series of surgical and orthopedic YouTube teaching video cast for undergraduate and postgraduate medical students. Today's topic is pathophysiology of spinal cord injury. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Like traumatic brain injury, spinal cord injury is also a dynamic process. Spinal cord injury involves a two-step mechanism involving primary and secondary phases. This concept of two-step mechanism in spinal cord injury was introduced by Allen in 1911. The full magnitude of injury is not apparent initially, and incomplete cord lesions may develop into more complete lesions. In a matter of hours to days after the initial event, the injury level rises 1 to 2 spinal levels. This clinical deterioration occurs due to a complex cascade of pathophysiological events like free radical injury, vasogenic edema, and compromised blood flow. Though there are many different mechanisms, three common mechanisms lead to secondary tissue damage. These are injury from direct trauma, compression from fracture fragments, hematoma or disc material, and ischemia from injury to or impingement on the spinal arteries. Any of these types of events cause progressive edema and ischemia, causing secondary damage. Therapeutic measures should be directed at minimizing the secondary injury. Primary spinal cord injury. Primary injury is a mechanical injury resulting from direct trauma to the neural elements and occurs at the time of the initial injury. Initial injury may be a mechanical disruption, transection, or distraction of neural elements as a consequence of fracture and or dislocation of vertebrae, damage to the ligaments, or penetrating injuries from bullets or weapons. Extradural pathology such as hematomas may also cause a primary spinal cord injury. It has been reported that ischemia begins immediately after trauma and, if not treated, deteriorates in the first 3 hours and continues for at least 24 hours. Secondary spinal cord injury. Secondary spinal cord injury is usually caused by hemorrhage, edema, and ischemia. It is accentuated by hypotension, hypoxia, spinal instability, and or persistent compression by the neural elements. Glutamate excitotoxicity, oxidative damage, nitric oxide production, free radical damage, and lipid peroxidation in cell membranes are associated with the secondary injury cascade. Apoptosis, Valesian degeneration, and cavity formation in traumatized areas also have been reported to participate in secondary injury. Mechanics of spine trauma. There is a wide variety of injury patterns in the spinal trauma due to its biomechanical complexity. The forces that are applied to the spine during trauma are mainly three types: flexion extension type, compression distraction type, and rotation type. Flexion loads the spine anteriorly and distracts the spine posteriorly. High flexion forces occur during head-on motor vehicle collisions and during backward falls when the head strikes the ground first. Extension loads the spine posteriorly and distracts the spine anteriorly. High extension forces occur during back-end motor vehicle collisions and during frontward falls when the head strikes first or diving into shallow water. Axial loading force compresses the spine. It loads the spine both anteriorly and posteriorly. Compression injuries occur when a falling object strikes the head or shoulders, or when landing on the feet, buttocks, or head after a fall from height. A force that pulls the spine axis distracts the spine. Distraction forces arise in cervical spine during a hanging or when the chin or the occiput strikes an object first during a fall. A force applied tangential to the spine axis rotates the spine. Amount of rotation depends on the range of motion of intervertebral facet joints. High rotational forces arise during off-center tangential impacts to the body or head or during glancing automobile accidents. Types of shock in spinal trauma. Three types of shock may occur in spinal trauma: hypovolemic shock, a spinal shock, and neurogenic shock. The hypovolemic shock most often occurs due to hemorrhage. It presents with tachycardia and cold calming peripheries. It should be treated with appropriate IV fluids and blood products. The term spinal shock refers to a transient extension of reflexes below the level of the spinal cord injury. It starts within minutes following the injury. There is a flaccid paralysis, anesthesia, absent bowel and bladder control, and loss of reflex activity. Initially, all the reflexes may be lost, but they gradually reappear. It is a temporary phenomenon and recovers usually in 24 to 48 hours, even in severe injuries. But it may take as long as 6 weeks for the return of the reflexes. Acute spinal cord injury may cause severe autonomic dysfunction and interruption of sympathetic nervous system control, resulting in a state of neurogenic shock. The neurogenic shock presents as the triad of hypotension, normal heart rate or bradycardia, and warm peripheries. This condition usually occurs due to unopposed vagal tone resulting from cervical spinal cord injury at or above the level of sympathetic outflow from T1 to T5. Neurogenic shock needs to be differentiated from a spinal and hypovolemic shock. In hypovolemic shock, there is tachycardia, whereas in spinal shock, there is an initial increase in the blood pressure due to the release of catecholamines followed by hypotension. The combination of hypotension and bradycardia should alert the clinician to this cause of shock rather than hemorrhagic shock, which may coexist, particularly in patients with other injuries. Complete and incomplete spinal cord injuries. A spinal cord injury can lead to several characteristic presentations based on the anatomy of the injury. Complete spinal cord injury. A spinal cord injury is complete when there is no motor or sensory function below the affected level and the perianal sensation is gone. Patient must have recovered from a spinal shock and their bulbocavernous reflex is intact before an injury can be defined as complete. It is classified as an ASIA-A spinal cord injury where there is no motor or sensory function preserved in the sacral segments S4 and S5. Incomplete spinal cord injury. Incomplete injuries are those with some degree of retained motor or sensory function below the site of injury and there is intact perianal sensation. These are graded B through D on the ASIA impairment scale. Incomplete spinal cord injuries include anterior cord syndrome, posterior cord syndrome, central cord syndrome, cauda equina syndrome, conus medullaris syndrome, and Brown-Séquard syndrome or hemisection.